Thank you for your interest in our presentation. Today, I'm going to provide an overview of the systematic review, which was focused on co-design approaches involving older adults in the development of electronic healthcare tools. My name is Amy Cole, and I'm presenting today on behalf of my colleagues Karthika Dappa, and Dr. Daniel Richardson, and Dr. Lucas Mazur. Our agenda for this presentation is to discuss co-design approaches and why it matters, as well as the objectives, methods, results, and conclusions and future research from our systematic review, as well as acknowledge those who support our research. So first, to provide a definition of co-design, co-design is meant to approach and elicit ideas and foster a non-hierarchical environment in which concepts, tacit knowledge, and lived experiences of stakeholders, including the target population, are applied to develop tools that meet the needs of the population. For co-design to work effectively, stakeholders must be provided opportunities to equally engage and have their values and culture incorporated into the development process. So why does this matter? I'm sure it will come as no surprise that we discovered heterogeneity in the definitions represented across the studies. And while this can present challenges, what is of note is that within this review, it's not so much on the approaches used, but how they're interpreted and then employed to determine what user involvement encompasses. So we conducted a systematic review to synthesize the current state of utilizing co-design approaches with older adults in the development of electronic healthcare tools. Our aim was to evaluate the extent to which co-design approaches engage older adults throughout the development lifecycle. We reviewed and extracted evidence from the literature to categorize the terms used to describe co-design approaches, as well as to draw themes around how these terms were defined. Our findings suggest that co-design approaches aim to involve end users in the development of electronic healthcare tools. However, we found that there are gaps in the evidence to support the levels in which older adults should be involved and the extent to which this involvement can increase the user's knowledge of the term technology, either limiting or encouraging their collaboration and empowerment. To ensure studies are optimizing the involvement of older adults when developing electronic healthcare tools, improving existing co-design frameworks to meet the needs of older adults should be evaluated. So we were interested in the co-design approaches used from studies that involve older adults, defined as those aged 60 and older, in the development of electronic healthcare tools, specifically tools used to inform their healthcare decisions. We first registered our review with Prospero, and then thanks to help from UNC Health Science librarian Jennifer Bisram, who helped us with the literature search strategy, we were able to look at articles published from January 2010 to March 2021. We also did a quality assessment using the National Institute of Health framework. Our initial database search returned 835 articles, of which 210 were duplicates, leaving 625 articles for the title and abstract review. Upon completion of the title and abstract review, 156 articles remain for a full text review. Ultimately, 25 studies were remaining that met inclusion criteria. Summary characteristics were extracted to provide an overview of the studies. Data from each study were extracted and divided into the three categories you see here: co-design approaches, stakeholder involvement, and electronic healthcare tools. The variables extracted for co-design approaches consisted of terminology and definitions, theoretical frameworks, as well as iterative development. We also extracted variables for stakeholder involvement, including participant types, types of involvement processes, and levels of participation. The variables for the electronic healthcare tools included the types of healthcare tools, as well as older adults' needs addressed by electronic healthcare tools, and finally, user testing. We then mapped the included studies on involvement processes utilizing Leononen's framework and the levels of participation utilizing Vaughan's framework. We cross-classified the types of electronic healthcare tools utilizing the World Health Organization's classification of digital health interventions with the needs of older adults addressed by electronic healthcare tools utilizing the work of Herman et al. Overall, our studies included participants in the age range of 60 to 91, with a mean of 71.4 years of age and a mean sample size of 40.8 when we included all participant types. The study setting included laboratories, clinics, homes, community and senior centers, as well as Zoom sessions. Studies were completed in the 8 countries displayed here. Overall, 9 different co-design approaches were represented in the 25 studies, as you see here. 18 different theoretical frameworks were reported in the included studies, and 19 of the studies were conducted in multiple phases with an overall mean of 3.4 phases per study. 151 involvement processes, which represented 4 distinct stages, as you see here, from contextual inquiry, participatory design, product design, and functional prototypes, were extracted from the included studies. Each study utilized between 2 to 11 involvement processes, with a mean of 6 processes per study. The levels of participation were also extracted and classified based on Vaughan's framework, which represent the 5 levels of participation you see here of inform, consult, involve, collaborate, and empower. All 25 studies were classified as level 1 inform and level 2 consult. Vaughan defines inform as the sharing of information among community members and consult as soliciting feedback from stakeholders at a particular decision point. 24 of the 25 studies were classified as level 3, which is involve, defined as participants providing feedback throughout the full process. 16 of the 25 studies were classified as level 4, which is collaborate, defined as participants being involved as co-leaders and having an equal role in decision-making. And finally, 15 of the 25 studies were classified as level 5, which is empower, and defined as participants taking a lead in engaging others on the usefulness of the tool. As you can see, the levels of participation change when we compare from all 25 studies, which can be viewed in the first level of inform yes, to those classified as level 5, empower yes. Here we note an increase in contextual inquiry from 4% to 5%, and functional prototyping from 10% to 14%, and a decrease in the utilization of participatory design from 60% to 55%, and product design from 24% to 23%. Now, this becomes much more distinct when we compare the utilization of processes in the 10 studies that were classified as level 5, empower, no, versus the 15 studies classified as empower, yes, as we see a decrease in participatory design from 69% to 55%, and an increase in functional prototypes from 2% to 14%. We use the World Health Organization's classification of digital health interventions and found that out of the 25 studies, 12 developed tools that span multiple categories within this classification. 16 of the 25 studies focused on a tool that supported searching for health information on a particular topic. 18 of the studies focused on health tracking, of which 3 were specific to accessing a personal health record, 7 focused on wearables or sensor technology for tracking purposes, and 8 focused on journaling or documenting current health status and activities. Additionally, 4 studies focused on communication of health information, and 2 focused on reporting on interactions with healthcare workers. We also categorized older adults' needs by using Herman et al.'s definition and adapted these definitions to identify older adults' health needs addressed by electronic healthcare tools. The majority of studies focused on patient engagement. So, as anticipated, we found heterogeneity within the definitions used to describe co-design approaches. Overall, we found 9 definitions were represented across the studies, and the general themes presented suggest that the approaches could be used interchangeably. And while this may further exacerbate a problem and lead to inconsistent use of terminology, what is of notable importance within this review, again, is not so much on the approaches used, but how they are interpreted and then employed to determine what user involvement means. Not surprisingly, each study specified either definitively within their aim or subsequently that end users should have some level of involvement or participation during the development lifecycle process. However, fewer studies indicated that participants had an equal level of decision-making when making iterative changes to the design, and even fewer empowered the participants to take a lead in engaging others on the usefulness of the tool. Of interest is that within the studies that empowered participants, we observed an increase in the utilization of specific involvement processes, such as contextual inquiry and functional prototyping. And while we found inconsistency in the involvement processes among the studies, over 70% included interviews and prototyping, and others included a range of processes such as cognitive walkthroughs, think aloud sessions, scenarios, focus groups. And only 20% of the studies utilized contextual inquiry and use cases. To the best of our knowledge, current frameworks or principles have not provided guidance on distinguishing the levels of participation, nor the validated involvement processes that should be utilized when engaging older adults in developing electronic healthcare tools. So here we focus on Leononen's framework for processes and Vaughan's framework for levels of participation. And after extracting the variables from all the studies, we overlaid these on top of the two frameworks and began to recognize the area in which we needed to further explore. So if the purpose was to involve end users in the development process, we have to be cognizant of the end goal and whether that is to develop a tool that will be useful and utilized, or more importantly, to develop a tool that through the involvement process can also bring a sense of empowerment to the end user. Work from Holden et al. Suggests separating co-design processes from outcomes and focus on the role that participants have to be co-designers and co-initiators, which supports the values defined by the fourth level of collaboration and the fifth level of empowerment. We suggest that we should be looking at involvement as a process, one in which users have the potential through involvement processes to inform, to empower, as highlighted in Vaughan's framework. This happens as they are engaged in processes of contextual design, participatory design, product design, or prototyping. Further, we suggest that additional exploration as to the extent to which a greater understanding of the tool can contribute to richer feedback. Therefore, suggesting the levels of participation are bidirectional, as depicted here, and when realized within the development lifecycle, will result in greater contributions to the development of the tool. Overall, the majority of our studies focused on tools that provided the ability to search for information on a particular health topic, or that allow participants to track their health information through self-monitoring. Through further cross-classification, we indicated that most tools in the included studies were focused on patient engagement. If the intent is to develop a tool focused on engaging patients in their healthcare decisions, and positive impacts have been reported in the utilization of electronic healthcare tools, and improvements to the tools are supported through appropriate involvement, then further evaluation needs to occur to ensure older adults are involved at the appropriate stages and engaged at a level that promotes the flow of bidirectional knowledge. And to include our limitations of the study, as our inclusion criteria span an array of terms that we categorized as co-design approaches, we had several approaches that were only represented by one study, which may not fully represent all studies that incorporate such approaches. In areas in which we extracted the levels of participation, specific evidence was difficult to draw out as to which levels of engagement were employed at specific processes. Therefore, generalizing this information was limited. Evidence was also extracted to classify the electronic healthcare tools, but as each tool did not fit precisely within the WHO classification or Herman's technology needs classification, it was difficult to ensure each tool was represented accurately. This review depicted not only the heterogeneity in the terminology used to define co-design approaches, but the plethora of frameworks and principles utilized when stating co-design approaches are being applied in developing a tool for older adults. Most studies in this review developed an electronic healthcare tool specific to patient engagement and designed their study to include older adults' feedback in the design, indicating a collaborative focus centered on meeting the needs of this population. While evidence extracted from included studies suggests that co-design approaches aim to involve end users in the iterative development of healthcare tools, we believe there are gaps in the evidence to support the levels at which users should be involved and the extent to which the involvement can increase the user's knowledge of the technology. Evidence extracted from the studies suggests that involvement processes utilized may be related to the levels at which stakeholders participate and can either limit or encourage collaboration and empowerment of stakeholders. To ensure each of these factors is optimized, additional research is needed to evaluate the feasibility of developing a co-design framework specifically for developing electronic healthcare tools for older adults. And for acknowledgements, we would like to thank Jennifer Bisrong for assisting with search strategies, adding studies to Covenants, and acquiring full text articles. And we would also like to thank UNC Health for their ongoing support devoted to our research efforts. Thank you very much for your time today. The following slides are a list of our references.